You're listening to an Airwave Media Podcast.
Welcome to Unbiased Science, where we bring scientific method to the madness. We're your hosts, Dr. Steier
and Dr. Sarah Scheinman.
And today we are tackling a topic that is all over the news, a topic near and dear to my Lexapro heart, SSRIs. And we have a very special guest joining us, Dr. Ben Rein, who is an expert in all things neuroscience. So I feel like I have two neuroscience geniuses with me. So I'm going to be doing a lot of listening and learning on today's episode. But no, I'm really excited to get into this. Lots of questions out there, some misconceptions, some myths, some wild claims. So we're going to get into all of it. Ben, thank you so much for joining us today.
Thanks for having me. Really excited for this.
All right, I'm going to read your bio, which is hella impressive. I'm just going to preface it with that.
It's lofty.
It is lofty, but I want to read it. It's so good. Okay.
It is. I feel like a bit of an underachiever reading this.
For real. All right. Dr. Ben Rein, PhD, is a neuroscientist and science communicator whose research is focused on the neurobiology of social interactions. He has published over 20 scientific papers in peer-reviewed scientific journals about the neuroscience of empathy, the genetic basis of autism spectrum disorder, and how communication between brain cells regulate social interactions. While working at Stanford University, Ben characterized how MDMA acts in the brain to enhance empathy. So many questions about that. His research has been honored with awards from the NIH, the Society for Neuroscience, and Sigma Xi. Outside of the lab, Ben creates educational science videos for an audience of over 1 million social media followers. His videos summarize recent research papers, teach neuroscience basics, and debunk viral videos containing misinformation. No shortage of that these days.
Seriously.
They've received over 60 million views and have been featured on Good Morning America, ABC News, and other major media outlets. He's been profiled by Popular Mechanics and Spectrum News, appeared on Entertainment Tonight, and joined over 40 podcasts, including Star Talk with
41.
Oh, including this one. Yeah.
Yes.
Let's go.
Wait, including Star Talk with Neil deGrasse Tyson, which is wild. Ben's science communication efforts have been recognized with awards from the National Academies of Science, the American Association for the Advancement of Science, the Society of Neuroscience, and Stanford University. No biggie. All right, he currently serves as the Chief Science Officer of the Mind Science Foundation and has served as a scientific media consultant for more than 35 companies and foundations. He's a contributing editor at Open Mind Magazine and the founder and president of the Aspiring Scientists Coalition, an organization providing free guidance for students in 75 plus countries. Ben, do you sleep or what?
Yeah, I sleep a lot. I have narcolepsy actually, so I'm pretty tired all the time.
Wait, are you being serious?
Yeah.
Well, that could be a whole topic in and of itself.
Yeah, that's a whole podcast right there.
It is.
My bio was a whole podcast as it is, so I appreciate you reading the entire thing.
I had to. It was so cool. Wait, we seriously do have to have you back to talk about narcolepsy if you're down for that. Oh my gosh, so many questions. And wait, real quick, did I just read you're teaching a course on?
Correct.
Tell us.
Yeah, so I'll be teaching a class at Stanford this coming semester. Enrollment opened yesterday. I don't know when this podcast will come out, but Stanford students enroll. It's on science communication. It's called How to Communicate Science, the Tools and Responsibilities of Public Messaging. I'm teaching it with Dr. David Eagleman, who's, for those in the neuroscience field, a legendary science communicator. He's published, 7 or 8 books. He had a TV show on PBS. He has a podcast right now that's leading. And we're also going to have a handful of guest lecturers. And the cool thing that I'm really excited about is the neuroscience PhD program at Stanford just approved it to be a formal part of the program curriculum, in that, not that it's required, but that if you take it, it counts towards the PhD, fulfilling the credit requirements.
Good. That's so important. I wish more universities would have courses like that. I feel like they're very rare to come across, unfortunately.
I'm pumped up about it. I'm really excited because for a long time I've been just telling universities we need to educate scientists on how to communicate clearly. It's important. It's critical to the field and to their career, and it just doesn't happen. And so now I'm very excited to be launching this.
For undergraduates and graduate students, I think it's important at all levels of education.
Yeah, and the class is open to both, so please enroll.
If you need any guest speakers, you know where to find us. Now,
I know. We have no shortage of amazing guest speakers, and yeah, we're gonna have to extend the class by like 20 semesters, and we'll get you all in there.
Cool. All right, so let's get into today's topic. I alluded to it, but I'm just gonna come out and say that SSRIs. I say that Lexapro, which is an SSRI, we'll get into it in a sec. I really feel like it saved my life. I've been very open about my struggles with anxiety and depression, and it took me a while to get proper care. It's very difficult often to get in with psychiatrists or psychologists, but I finally did. And, this medication has really revolutionized my life. Okay, I'm going to give a little bit of a background, and I feel weird reading this to two neuroscientists who know this a lot better than I do. So I'll say this, and then just feel free to jump in and correct me if anything.
But Jess, our audience does not consist purely of neuroscientists. So it does make sense to do a bit of a background on this, including like what SSRI even stands for. I feel like a lot of people don't know that.
Well, that's a good starting point. So yes, SSRIs, selective serotonin reuptake inhibitors, were first developed in the 1970s and revolutionized the treatment of depression and anxiety disorders. The first SSRI was Prozac. What is it? Fluoxetine? I'm probably saying Fluoxetine. There you go. It was approved by the FDA in 1987 and quickly became one of the most widely prescribed antidepressants. SSRIs, well, we're going to hear a lot more about this from Ben and Sarah, but they work by increasing serotonin levels in the brain, which helps to regulate mood, emotion, and sleep. Compared to older antidepressants like, oh God, I'm going to be totally botching this, tricyclic antidepressants, TCAs, and monoamine oxidase inhibitors, MAOIs.
You got it.
SSRIs were seen as safer and better tolerated with fewer side effects and lower overdose risk. Since Prozac's introduction, several SSRIs have been developed, including Zoloft, Paxil, Celexa, Lexapro, and Luvox. Now, they're among the most commonly prescribed medications in the U.S. So according to the National Center for Health Statistics, approximately 13.2% of U.S. adults reported using antidepressants between 2015 and 2018, with women being nearly twice as likely as men to use them. A report from the CDC indicates that antidepressant use has increased significantly over the past 2 decades. They're primarily prescribed for major depressive disorder, generalized anxiety disorder, obsessive compulsive disorder, and post-traumatic stress disorder, among other mental health conditions. And just to set the stage, I alluded to this, but they have been the topic of conversation with some people saying that maybe we're overprescribing them, or that perhaps there are some dangerous side effects that are not talked about enough. So
people are also saying that they're addictive substances and that they have like addictive potential too. So we're going to cover all of this today.
We are. So Ben, Sarah, I don't know who to bug about this, but can we talk about the mechanism of action? So how does this actually work, and what does it do to our brain?
Yeah, I want to point something out. What was the website you were reading off of there?
CDC.
CDC?
Yeah, one was CDC and one was the National Center for Health Statistics.
So I noticed a science communication error in there. It's a nitpicky error. They said, what you read said, SSRIs increase the level of serotonin in the brain.
Yeah.
Not technically true. SSRIs increase the level of serotonin in the synapse, which is where it counts. And so what SSRIs do is when a serotonin producing neuron, which I will call serotonergic neurons, when they release serotonin, it can bind the receptor, do whatever, it can sit around. And then eventually neurons have this sort of like return to sender function, where you could think of a piece of a neurotransmitter being released between neurons in the synapse. Let me just back way up for a second. Neurons communicate at synapses. One neuron, the presynaptic neuron, sends a neurotransmitter, like a piece of mail, I like to describe it, and that binds to a receptor, oftentimes with like a mailbox, and then that sends the message to the next cell. But anyways, like I said, there's this kind of return to sender function where the the neurotransmitter can go back to the neuron that sent it out and be reabsorbed and recycled for further use. And that's reuptake. So what SSRIs do, they're selective serotonin reuptake inhibitors. They block reuptake. So that serotonin, instead of getting slurped back up into the cell that sent it out, it sticks around in the synapse and continues to activate the serotonin receptors on the receiving cell, which means that overall, over time, where normally serotonin would get slurped back up and the serotonin signaling ends, that doesn't happen. Instead, the serotonin signaling process continues for longer, and overall, it just enhances the level of serotonin signaling in the brain, in the synapse.
Yeah, like how I like to think about it is it makes the connections a little more efficient between the serotonin neurons. So it just makes it so that they can talk to each other like a little bit more easily. Like Ben says, it doesn't actually produce serotonin, which is really important to keep in mind, but it just makes it so that the connections are just a little bit smoother.
Now I'm looking at our show notes and I see, was there a controversy back in, it looks like 2022? Ben, can you tell us about this?
Yeah, I'm so glad we're talking about this because it's so important. So in early 2022, I'm just going to give my personal perspective on this. In early 2022, a friend of mine said, hey, let's make a video about the neuroscience of depression on social media. And we did. And so I did this whole literature review. And I was looking around and I'm looking for evidence like, okay, there's got to be evidence somewhere that low serotonin is, happens in depression. Seeing as serotonin targeting drugs alleviate depression, there's got to be low serotonin. And I couldn't find any evidence really. Like there's very poor mixed evidence. And I was like, that's weird. I always thought that. And so I made the video and I explained that, whatever. And then like a few months later, this huge study comes out. It's a review paper where they did exactly what I did. They reviewed the literature looking for evidence that low serotonin causes depression. And just like what I saw, they found that there is very poor evidence overall. There's not a clear indication that low serotonin drives depression or even happens in depression. And this became this massive news story where Tucker Carlson is like, for years they've been saying that low serotonin causes depression and that's why they put you on SSRIs because, that's allegedly how they work. But now this research says that it's not low serotonin, so you shouldn't be taking SSRIs because SSRIs wouldn't make sense to be taken. Like it became this huge blow up story that attacked the credibility of SSRIs because, the most simplistic explanation is that it's low serotonin. And that's extremely problematic because the problem doesn't have to be low serotonin for enhancing serotonin to help. It could be something completely different, and there could be some downstream indirect mechanism through which the serotonin targets what the actual root problem is. And, I was fired up about this. I posted about this on social media a few times because just the pathology of the condition doesn't changing, the way we view what causes it, that does not invalidate all the studies that have shown that SSRIs are effective for treating depression. And it frustrated me that these media outlets were using this as an opportunity to discredit SSRIs in this very kind of naive way, that really bothered me. And so, I'm glad we're doing this episode and talking about it now.
Well, I think it's also important to keep in mind that conditions like depression are very multifaceted. And it isn't just one type of neuron and one type of neurotransmitter that's affected. I mean, and I think a piece of evidence in support of this is the fact that there are other antidepressant drugs other than SSRIs. So there's a drug called SNRIs, which target norepinephrine. There are monoamine oxidase inhibitors, like Jess mentioned, and tricyclic antidepressants, like Jess also mentioned. And I think the fact that these drugs are also effective in treating conditions like depression just goes to show that it isn't just one type of neurotransmitter, not one type of drug of chemical in the brain that's being changed when you have a mood disorder.
So Ben, you said something that I want to come back to. You said, so it doesn't refute all the evidence that we have that SSRIs are effective for depression. So can we just talk a little bit more about that body of evidence? And then also, in reading about SSRIs, it looks like they're used to treat both depression and anxiety. So is the evidence different for treating anxiety?
Yeah, the evidence is very strong for both. And, when I say very strong, what I'm referring to is, anybody can look this up. If you look up SSRI meta-analysis depression or SSRI meta-analysis anxiety, what you will find is many studies which they've combed through the literature, found numerous clinical trials that have tested whether or not SSRIs alleviate anxiety, depression, and summarized all the data. And, you have studies with tens of thousands of people altogether. These meta-analyses, they include that many people. And they just look at, what are the effect sizes? Do SSRIs effectively, alleviate depressive symptoms? And of course they do. If they didn't, they wouldn't be prescribed all the time and as commonly as they are. And, I do want to point out, though, a few positive things and a few negative things here. The positive things are, one of these studies, and I can send you these references, they show that there's actually a dose response curve, which means that the higher the dose, the greater the symptom alleviation, which is exactly what we would want to see. That strongly suggests that the drug's actually doing what we want it to do. The second thing is there's also not only behavioral survey evidence, because the way you can test, is someone depressed, you ask them to fill out a survey and they describe how they're feeling and they get better. But people that take placebo in many cases also have their depression temporarily cured. And that's, something to note. And that's also why that's a common criticism on the studies. But of course, SSRIs always outperform placebo. And I think that what takes this evidence a step beyond just, do people report being less depressed, because that's something that placebo can do. There's plenty of neurobiological evidence showing that, for example, people with depression show enhanced responses in the amygdala, this emotional center of the brain, when looking at emotional faces. And which suggests that maybe if they have an enhanced, maybe negative emotional reaction, and after taking SSRIs, that response is diminished, which suggests that it's actually changing the way the brain processes information. People with depression also show smaller volumes, a reduced size of specific brain areas in the prefrontal cortex and the hippocampus. And SSRIs have also been shown with long-term use to restore, enlarge those brain areas, which suggests that, it's not placebo, it's actually doing something. But with all that said, the negative side, we also have to acknowledge that, I mentioned that dose response curve, that there's a greater effect with a higher dose. There are also more side effects with a higher dose. And that's because, probably SSRIs, or serotonin does a lot of different things in the brain, and SSRIs are just blanket targeting all those places in the brain where serotonin is released. And so, while those certain places that may be helping with mood, and other places that may be creating other off-target side effects that are not necessarily helpful. And so as the dose scales to higher points, you may induce more side effects. And the last thing, sorry, long rant here. The very last thing is that when I'm talking about these meta-analyses, we're looking at tens of thousands of patients, but of course, there are plenty of people in those studies that don't show relief. They don't experience relief from their symptoms. And there are plenty of people, anecdotally, who go through that too. And there are, a lot of people have treatment-resistant depression, where they may have to look at other treatments. And so I think that where a lot of the science messaging around this can go wrong is it's easy to look at a meta-analysis and say, well, look at the effect sizes. It's obviously helping people. But we have to acknowledge that not everybody is helped, because then it can be misleading. And as soon as someone starts taking an SSRI and it doesn't help them, they're going to immediately start to distrust the science and the people who shared it with them. So we have to acknowledge those limitations.
And not only does it maybe not work for everyone, but of course, there, as with all things, there could be side effects, right? And so I know, again, speaking for myself, just again, anecdote, I experienced some emotional blunting. So it kind of felt like I wasn't, like, the lows weren't as low, but the highs weren't as high. Like there was sort of like a numbness is how I like to describe it. I've also, what are other common side effects? I've seen some issues with nausea, libido,
changes in appetite.
Yeah, changes in appetite,
changes in weight.
Right. Yes. Weight. And so again, like with all things, and Ben, you're talking about this, our bodies, we're all, there's a lot of heterogeneity, right? Our bodies are going to react differently, to medications and to all things. So I think that that's important to note.
And I would like to just point out, too, that serotonin has a lot of different functions in the brain, too. It doesn't just regulate mood. So it does make sense if you're taking a drug sort of long term that targets that system in the brain and that neurotransmitter, that you would have some off-target effects.
Mm-hmm. So Ben, what about withdrawal? Is withdrawal a thing when it comes to SSRIs?
Sorry, before I answer this, I realized that I didn't fully answer your last question. I also just want to say there are meta-analyses showing that SSRIs are also, I don't want to say equally effective because it's hard to compare the studies, but very effective for anxiety and particularly social anxiety. So I just wanted to add that. Now, so when it comes to withdrawal, I want to preface this part of the discussion with two things. Number one, I've never taken an SSRI, so I can't speak to it from the experience. I'm speaking out of scientific papers, which isn't always the best way to speak about something. Secondly, I'm not a psychiatrist and I'm not an MD. I don't prescribe these medications. I don't speak to patients. So once again, talking from scientific papers. But yes, of course, there are withdrawal effects, and I think people need to be aware of that. When you're modulating your neurochemistry in a specific way for an extended period, and then you stop doing that, you are probably, just as, on your on-ramp in, you may have effects, on your on-ramp or your off-ramp, you may also experience effects, and those effects may be very negative. And, I can say, hopefully my mom doesn't listen to this podcast, but anecdotally, I remember when I was really young, there was a morning I was like in middle school, and I didn't want to go to school, of course. And I'm laying in bed, and I'm like, Mom, I don't want to go to school. I don't want to go to school. And I had this little fan that would sit on the ground, and I just aim it at me while I was sleeping. And my mom comes in. She's like, you're going to school. You're going to school. And my mom is very, lovely and level-headed. And she just starts freaking out, and she takes the fan, and she just starts smashing it on the ground like a gorilla. It was crazy. And the fan, explodes, and I'm, crying. I'm like, I'll go to school. I'll go to school. And later, I realized she was withdrawing from an SSRI at the time. And so ever since then, it's been in my head that, again, it's especially for a scientist to be like, anecdotes are the key. But when you see something like that, it sticks with you. And especially this is why when Tucker Carlson went on and was like, SSRIs don't work, that's why I got so upset about it, because I'm thinking thousands, maybe hundreds of thousands of people are going to watch this program, and they may think, you know what? He's right. I'm going to stop taking my SSRI and just stop cold turkey. And I think that is where the largest side effects can occur, withdrawal effects can occur, because you're just abruptly changing your neurochemistry where you're supposed to wean off of the drugs if you want to go off of them. And of course, consult your doctor.
Well, just one more anecdote. I totally empathize with Mama Rein, because I recently, so I mentioned that emotional blunting, and I was wondering, maybe there's another drug, maybe, I could switch to a different drug that maybe I won't experience that same emotional blunting. Guess who did not wean off her Lexapro appropriately? I switched to a different drug, totally different class, Wellbutrin. Not great. I experienced exactly what you're describing. I was so hyper irritable. Also unclear if this, maybe the Wellbutrin was exacerbating my anxiety, but I was having horrific panic attacks, anxiety attacks. Long story short, I'm back in the arms of Lexapro and doing a lot better. But
sweet arms.
Yes, sweet arms. Anyway, sorry, Sarah, were you about to say something?
Oh, I was just going to list a few more symptoms.
Oh, yeah.
Potential symptoms of SSRI withdrawal. So some people may experience flu-like symptoms like fatigue, headaches, muscle ache, sometimes chills. Like we alluded to, Ben and Jess mentioned emotional and psychological symptoms. So you can actually have increased levels of anxiety, irritability, smashing fans. Sometimes people experience increased levels of depression, which makes sense, because if you're weaning off of a medication that is supposed to help with depression, then you might experience a recurrence of those symptoms. There are also some physical symptoms that some people experience, which dizziness, nausea, changes in sleep patterns, tinnitus, so ringing in the ears. There are also some cognitive effects, like people will experience brain fog sometimes, memory problems, and then difficulty falling and staying asleep, and sometimes vivid dreams or nightmares. So not everyone who's withdrawing from SSRIs will experience all of these, but these are just some of the symptoms that are associated with abrupt stopping of an SSRI.
So would you say are SSRIs addicting? I don't know what the proper term is, but would you say addictive? Mm-hmm.
No. And this has also frustrated me. When it comes to the addictive liability of a substance, it's like, as far as I understand, pretty easy to tell whether something's going to be addictive if we know the pharmacology. If something targets, for example, dopamine signaling, like methamphetamine or cocaine, it's much more likely to have an addictive liability, to be addictive, because dopamine is inherently reinforcing. And dopamine is the brain's way of saying, this is good, we should do this more because it's good for us. Like you eat a delicious meal and you're like, wow, I should probably have this food again. Like dopamine helps your brain remember that thing was good. And so when you take something that stimulates dopamine release, your brain's like, wow, this is great, we should do this more often. And then that's why cocaine is so addictive, because it's doing exactly what the brain does to say, this is rewarding. Serotonin is not rewarding in that way. In fact, a paper just came out that actually showed that serotonin likely acts like a brake on dopamine. It actually suppresses the rewarding properties of dopamine. And so, for example, this makes perfect sense, because if you look at MDMA, a drug which I used to study in my last project, MDMA is methylene dioxymethamphetamine. It's like methamphetamine. It stimulates dopamine release. So you would think it would have a very high addictive liability, but MDMA also stimulates serotonin release simultaneously. And MDMA does not have high addictive liability. And it now makes sense with this recent paper, because that concurrent serotonin stimulation, when serotonin's also being stimulated, it actually probably blunts the reinforcing properties of the dopamine, which makes it act in a similar way in the brain, but not be as inherently reinforcing. So anyways, all that to say, there's no reason to believe that SSRIs would be addictive or reinforcing. There's another thing to recognize here, which is, there are other systems in the brain that could be reinforcing, like, opioid signaling, like pain relief, right? That's why it's very, very difficult for neuroscientists to develop pain relief drugs that are non-addictive. You might sort of theorize that like relief from depression could be reinforcing and rewarding. But the thing is with SSRIs, it's such a gradual onset. It's not like you pop it and then you're like, wow, I've, cured. It's not at all like that. And so, the argument that maybe the antidepressive effects would also be addictive is also poor and doesn't really make sense. So there's just no reason to say that. I think maybe, I'm very much postulating here, but maybe the reason why that has been brought up, that they're addictive, is because of the withdrawal effect. It's kind of reminiscent of those really reinforcing addictive drugs. But like, it just doesn't make any sense on so many levels.
Mm-hmm. So, Ben, you're all over social media. And by the way, I don't even think we said, where can people follow you? Sorry, before we forget. That's all right. I'm on TikTok and Instagram. I prefer Instagram a lot. TikTok is frustrating to use for many reasons. But yeah, like you said, in the business of debunking misinformation, there's a steady flow. So it's just a spout that keeps on spouting. But anyways, yeah, so yes.
And, I think my name, Ben Rein, should be sufficient to find my account.
Yes. Yeah, and we'll tag in our show notes. But I bring this up because you're probably seeing a lot of the myths, misconceptions, misinformation circulating about SSRIs. The one that I'm seeing a lot right now is that SSRIs are responsible for things like mass shootings or violent outbursts. Can you speak to that? Is there any evidence of that?
There's no evidence for that. And there's actually evidence against that. There is a paper, which I can send you, where they actually looked at this and they found that, there's no link between SSRIs and school shootings, for instance. And the trouble here is, even if there were a link, there's this massive confounding variable that nobody is talking about, which is depression. It's like, if you said, yes. if you said, hey, a new study came out that said that showed that people taking SSRIs are more likely to be in therapy. SSRIs must cause depression if they're going to therapy. No, they're in therapy because they're taking an SSRI. And so if somebody is more likely to, commit an act of, violence or self-harm or any of these things, to pin it on the SSRI is just a complete guess. And it's much more likely that this person is experiencing depression-related hopelessness that may have driven them to act in a way that is not, typical the way they would normally act. But there's just no reason, also biologically, to think that SSRIs would induce that kind of behavior. Also because serotonin is one of the brain's key social neurotransmitters. It has a very important role in driving pro-social behavior and social interest. And in fact, there are studies showing that people taking SSRIs basically become like, you might describe it as nicer. Like they're more tolerant. I said earlier, they have reduced social anxiety. But there's also studies where, like this one I really love, where people they put partners together and they had to solve a puzzle together, but it was super frustrating because only one person could touch the puzzle pieces at a time. And so the other person sitting there, like trying to give advice and stuff. And what they did was they had one person in each pairing not on SSRIs and one person on an SSRI. And they found that the people on SSRIs were much less likely to be like commanding and mean, and the people off SSRIs were much more likely to be like, oh my God, put the piece in that spot right there, please. And so, there's plenty of other evidence like this too, like in these like moral dilemmas where it's like, would you push someone in front of a train to save 5 others? Like people on SSRIs are much less likely to commit these very personal like acts of violence on others. So there's just no reason why SSRIs would do that. And, it's just another, I don't get the attack on SSRIs in psychiatry and stuff. I think it's part of a larger sort of goal to pull back from like pharmacology in general. I think there's this reliance on like natural methods and like, anything that's developed in a lab or, in a factory and it's a vaccine or it's a drug, whatever, like we got to stop that. It's bad.
Yeah. Yeah.
But I mean, I just don't really understand.
I didn't really understand either. And so, like, I actually looked into this a little bit. I mean, I Googled, like, SSRIs and school shootings. And what came up for me was, and maybe, like, this is where all of this misinformation is stemming from, is that children who are exposed to mass shootings at young ages are more likely to be on SSRIs, which makes sense, Ben, as you mentioned, because who are prescribed SSRIs? People with mood disturbances, with depression, with anxiety. And so, of course, if young people are exposed to like such violent acts at a young age, like, of course, they're going to be more likely to be in therapy, be potentially treated using SSRIs for their mood disturbances, their depression and anxiety. It does make sense. And like you mentioned, Ben, like there is that confounding variable of depression. Like people who commit violent acts are probably more likely to have mood disturbances and are therefore maybe more likely to be prescribed SSRIs. Like we're skipping this step.
Yeah, I also want to point out the fact that like, when it comes to suicidality, that's another thing. People say SSRIs induce suicide. There's actually studies, again, I can send these over so you can show them for the podcast if you'd like, showing that the risk of suicide increases in the 12 months leading up to right before people take SSRIs and then gradually declines after, which makes perfect sense because as that hopelessness reaches a peak, that's when people are probably most likely to either, sadly make an attempt at their own life or go to a therapist and say, or psychiatrist and say, hey, it's really time. I need something to help me out. And then after taking SSRIs, that gradually declines. But you can cherry pick that. Look at what happens to people in the 1 month after they take SSRIs, their suicidality reaches a peak, which relative to the rest of their life, yes, that's true. But it's actually because right before they were also reaching a peak and now they're still in that same period of hopelessness. And once again, also, the confounding variable of depression, and there's all these psychological factors that we need to acknowledge. What also I don't see people talking about is if you are experiencing severe depression and you go to a psychiatrist for maybe the first time and you say, look, I really need something. I think it's time. They prescribe you an SSRI. And then you are one of those people who are treatment resistant and the SSRI does not help. I feel like that may increase your level of hopelessness and that could really put you into a pit. And that's another like little kind of window where bad actors could point and say, look, after taking the SSRI, they showed an increased risk of suicide. And I think that's, just again, a manipulation of all these factors to make it look like SSRIs are doing this horrible thing, which they're presumably not.
So, Ben, first of all, there's a paper that just came out that I really want to talk about. But before we do, are there any other like glaring misconceptions that you've seen circulating on social media that like we'd be remiss if we didn't mention?
I mean, no like big controversies or anything like that. The one thing I do want to mention is, we talked earlier about SSRIs increase serotonin, but low serotonin isn't the problem. So I do think it's worth touching on, like, what might SSRIs be doing? Like, how do they work? And it's not, it's not like known. It's not pinned down, but there is a prevailing theory, which I personally, buy into, which is that it's very well known that serotonin drives neuroplasticity. It plays a major role in neuroplasticity. And it's been shown that SSRIs can induce neuroplasticity. And like I mentioned earlier, people taking SSRIs, these certain brain areas have been shown to enlarge. The only reason that would happen is if there are, the brain structures are changing. Maybe new synapses are being established, which, we have synaptic plasticity occurring. So there's a theory that synaptic plasticity is what's driving, or what's kind of leading maybe the antidepressant effects, which is that when you have this flexibility in your brain, you can start to, this is kind of hand-wavy and very theoretical in a way, but if you are experiencing this increased flexibility and you're going to therapy simultaneously and you're working on things that have troubled you for a long time, you have an increased ability to maybe reshape your perceptions and thoughts about these things and kind of just change the way your brain is functioning and change the way you're thinking about things. And that may also explain why people taking SSRIs typically don't experience any effects for the first couple of weeks. It could be because that it takes time for that neuroplasticity to set in and really start moving. Because otherwise, if it was really just a neuropharmacological thing that the serotonin alone was just doing something, you would probably expect that as soon as people took their first dose, they would feel like an immediate change. And most of the time, as far as I'm aware, they don't. So.
All right, so let's talk about this new paper that is getting a lot of traction. I've had at least 500 people send it to me saying
At least 500.
At least 500. So, okay, so there's a recent paper that investigates antidepressant use and cognitive decline in patients with dementia. So here are some conclusions drawn. So in this cohort study, current antidepressant use was associated with faster cognitive decline. Furthermore, higher dispensed doses of SSRIs were associated with higher risk for severe dementia, fractures, and all-cause mortality. These findings highlight the significance of careful and regular monitoring to assess the risks and benefits of different antidepressants use in patients with dementia. Sarah, you're our dementia gal. I don't know if you had a chance to look at this paper, if you have any thoughts. This is causing a lot of concern for people.
I do have some thoughts on this. And I think the first thing that's important to keep in mind, and something that's not always talked about when we're talking about conditions like dementia. So when people hear dementia, they think cognitive decline, they think memory impairments, changes in thinking patterns, executive functioning. But what also occurs when people have dementia is a whole slew of behavioral and psychological symptoms, and they're called BPSD, behavioral and psychological symptoms of dementia. And this is a whole area of study which just shows that people that have dementia also are more likely to experience symptoms like anxiety, depression, agitation, these types of things. And that goes hand in hand with the changes in memory and cognition. So what is important to keep in mind is that something like 90% of people that experience dementia symptoms, like changes in thinking and cognition, are also experiencing these behavioral and psychological changes. So that's a huge confounding variable that Ben alluded to earlier, that the fact that these patients are more likely to be depressed in general and are therefore more likely to potentially be prescribed SSRIs or other antidepressants. Now, another thing that's important to keep in mind with these types of psychological symptoms associated with depression is that scientists are starting to think that the depression that's caused by different types of dementia does not have the same neurobiological mechanism as depression that is caused in people that do not have dementia. So people that, are younger, are diagnosed with symptoms like major depressive disorder, that there's a different mechanism that's underlying the depression that's associated with dementia. So that's another thing to keep in mind as well. And Ben, I'm going to go ahead and turn it over to you. I want to hear your thoughts as well, but I just wanted to provide that background that a lot of people might not know about dementia when we're talking about antidepressant use in this population.
Yeah, thank you, because you said all that way better and more accurately than I could. I think, there's a few things to recognize with this study. First off, like I said, there are plenty of clinical trials showing that SSRIs are effective. There are also plenty of clinical trials showing that SSRIs are effective at treating depression in older people with Alzheimer's. Like there's a reason SSRIs are prescribed. Now, I looked at the study. I did not see a clear graph or experiment where they controlled for depression.
Yeah, me too. I noticed that as well.
That is a huge downfall because, okay, there are also studies showing that people who, I have my notes here, sorry, people who are older people who experience depression, they show faster cognitive decline, lower levels of BDNF, brain-derived neurotrophic factor, and greater brain atrophy. So greater brain shrinkage. So essentially, all this effects that are described in this study have been linked to being depressed in later life. So the fact, it's again a confounding variable, that the fact that they were taking SSRIs, they were also depressed. Which one is it? Is it the one that has been linked already to these effects, or the one that has been shown to actually reverse these effects that we're talking about and increase brain volumes through driving neuroplasticity? It's probably the depression. And the fact that they did not control for the presence or absence of depression in these patients says a lot, because they should have done that experiment. They had the data sitting right there. The fact that they did not include that graph tells me that probably it didn't show it didn't support the conclusions of the paper, and that's bad science.
Absolutely. And just a note for our listeners, we are going to do a deep dive on that specific study. We'll be leaning on, Sarah's neuroscience expertise. Ben, we're going to be bugging you for this as well. And then I'm going to approach it from a data science perspective, research design perspective. But absolutely, like data science 101, you have to, assess for reverse causality and very, very clear confounding variables. So, all right. Any final thoughts, Ben, on the topic of SSRIs, or, just final takeaways for listeners, things you wish people would know about these drugs?
I'm just taking a look at my notes here, see if there's anything that we didn't hit on. I don't think so. I think we touched on everything. I do want to comment again on that last study. I as often as I can, I step outside of myself and I think about the viewer, the listener, and I think about the listener with two attitudes. One being a person who takes SSRIs and knows that they're important and doesn't want RFK Jr. to take them away, and the other being a person who loves RFK Jr. and thinks that SSRIs are dangerous. And that person's perspective, listening to this conversation about that study we just discussed, what we just did is we presented this study. It's a peer-reviewed scientific paper. It's been published. And we pointed out a bunch of criticisms. And it's easy for that person who distrusts SSRIs to look and say, wait a minute, the three of you trust science when it says SSRIs are good, but you don't trust science when SSRIs are bad. And I think it's important to acknowledge that all of this science could be flawed, and it's important for everybody to always look very critically and carefully at any information. And so even in peer-reviewed scientific journals, the information can be imperfect. And what I learned through my scientific training is that you should always do every single experiment that you possibly can. It doesn't even matter. Throw it in the supplemental materials. Just do it, because that is how you convince people and peer reviewers that the science you're doing is actually legitimate and that the conclusions you're coming to are well-informed and valid. And so when a study fails to do that and makes a very big, important claim that's getting thousands and thousands of views and a lot of traction and is being weaponized against something that has a lot of positive scientific evidence, we have to say something and we have to point out those flaws. And if the study said the opposite, I would have the exact same criticism. So we need to recognize that when everything's polarized and divided, information is still information. And it doesn't matter which side of the argument you're on, you need to be critical of all information. And I'm comfortable doing that even with my own beliefs, and I wish more people were.
Oh, Ben for president. Oh my gosh. Ben, that was so beautifully said.
Well said.
There is actually one final thing that I did see in our notes. I feel like we wanted to touch on it, maybe like in literally less than 1 minute. Just maybe a note, Ben, about the difference in, our perspective as, PhDs or DRPH, right, versus an MD. MD, like maybe just talking briefly about how our I mean, you did touch on this earlier, right? Like you acknowledge you're reading the research, you're in the research, and that is very different than, sitting in the role of an MD or a DO, a clinician. Do you want to just briefly touch on that?
Yeah, again, I think about from that same perspective, and it's, again, very easy for someone to look at any of us, the three of us, saying something good about SSRIs and them to accuse us of being biased because we prescribe SSRIs and so we benefit financially from SSRIs. But that's not true. None of us, you guys don't, you don't prescribe SSRIs, right?
Nope.
Yeah, none of us prescribe SSRIs. Right, exactly. Yeah, so with a PhD, you cannot prescribe SSRIs. I have no financial incentive. You can check my tax statements. I'm not paid by Big Pharma. I'm just relying on the data. And when the data say something incredibly clear, that's what I'm going to tell the people, And so, again, it's like there are many accusations commonly about being biased, but like genuinely, truly, all I'm ever trying to do is share the data, because when you rely on data and you actually trust that the information is valid, when it appears to be valid and it's scientifically sound, it's often useful for guiding your life. And it can often lead you in a place that's helpful and it can help you make better decisions. And I think that's important. And so, anyways, all that to say that like the criticism of us potentially being biased on the Unbiased Science podcast is invalid. So.
Oh, goodness. Yeah. We have to create a soundbite from that. I'm just going to play that over and over again. Love that. Dr. Ben Rein, thank you so much for joining us. Everyone should go and follow Ben on social media. We're going to tag him, in our show notes so you can follow along. Thank you so much for joining us today.
Of course, this has been a lot of fun. I really appreciate it. Not all podcasts. The other 40 haven't been as fun. So,
you just made it.
Neil deGrasse Tyson. So
yeah, that one was pretty fun, but I was really nervous.
Oh my God, I don't
Understandable. All right, Sarah, you want to take us home?
All right, thanks everyone for tuning in. We hope you learned a thing or two. Please join us next week on your trusted source for no nonsense, just science.